Hello, everyone, and thank you for joining today's webinar. My name is Jennifer Yang, and I am the Technology Coordinator for today's session. Before we begin, I'd like to remind everyone that today's webinar will be recorded. Once the recording is available, we will send out the link and the slide deck to the link to the recording and the slide deck for the presentation via email. Also, everyone is muted to reduce background noise, but we want to hear from you throughout this session. At this time, please click the little bubble on the bottom with the chat icon on it, and to enable the chat panel, which should be on your right. Please feel free to chat in all of your questions and responses throughout the webinar to the attendees there. If you experience any technical difficulties, you can also chat me through the chat message, and I will be happy to assist you. Thanks so much, and at this time, I introduce Marcella McGuire from the Corporation for Supportive Housing.
Hey everyone, welcome, and thanks for joining us today for today's webinar. Let's see, we are having just a couple of technical difficulties with one of our presenters, so please bear with us today. Thank you. This is the third webinar in a series sponsored with HRSA's support by the National Healthcare for the Homeless Council and Corporation for Supportive Housing, presenting a webinar series on addressing the opioid crisis. This is webinar number 3 in the series. Webinar number 1, and we're happy to share those materials with widely, was for addressing the opioid crisis at the systemic level, talked about new resources in the Support Act and how addiction treatment and services system are structured. Webinar number 2 talked about state activities related. We heard from Rhode Island, Pennsylvania, Missouri, all talking about innovative programming related to addressing the crisis. And today we're going to, I think, where all of us really want to get to, which is the program level, some innovative program, particularly with a focus on addressing unsheltered homelessness. As Jen said, and if we will have an active chat here, so please note that who you are sending the message to. Feel free to send to me or any of the panelists, but I think it's helpful for everybody to hear the questions and hear the answers. So put in all panelists would be, all participants would be my recommendation for when you're chatting with folks, so everyone can hear what it is you're asking. So we have great presenters today from doing really interesting programming from San Diego, from San Francisco, and from Philadelphia. I also want to highlight one of the interesting pieces of the mix here is that all of these come from agencies that have long-standing histories in the community and maybe had a different emphasis. We'll hear about San Diego coming from the homelessness sector, as opposed to Philadelphia coming from the needle exchange and HIV prevention sector, as opposed to San Francisco coming from the public health department. Though each ends up with very similar ideas, very similar, somewhat similar models, and really stepping up to address the crisis in their community. So we're really grateful for that. And with that, I am ready to turn it over to Megan Parch, Dr. Megan Parch from Father Joe's Village in San Diego. So Megan, you still look like you are muted from my line. So. There you go.
Are you able
now
to hear me?
From you. Welcome, welcome.
Thank you so much. So, as Marcella had mentioned, my name is Megan Parch. I'm the clinic director at Father Joe's Village's Village Health Center. I do that work by day. In the evening, I'm also an adjunct faculty member at San Diego City College, where I teach alcohol and other drug studies programming. So we are excited to share some information with you about the way that we're addressing opioid use disorder in the homeless population in San Diego, California, and we'll go ahead and hop right on in. So first I wanted to share with you some of the challenges that we're facing on the national level, as well as within our San Diego community related to homelessness, and then also breaking down some information related to opioid use and opioid use disorders. We know that San Diego has the 4th largest homeless population in the United States, and that nationwide homeless on any given night is about 552,000 individuals, which breaks down to about 67% of singles and 33% of families. In California, the homeless population is around 130,000 individuals on any given evening, and we have the highest number of unsheltered homeless individuals in any state. When we shift gears to look at the impact of drug overdose and opioid use in the United States, we know that overdose is a leading cause of injury and death in the United States, and that many individuals transition to the use of illicit substances after having been prescribed medications related to pain. We know that substances obtained on the street are often cut with other substances, which increases their potency and unfortunately leads to additional overdose we see here are overdose death rates involving opioids. This is provided by the CDC, and we can see that of any and all opioids, the number of overdose-related deaths just continues to be on the rise. And so we certainly have, as many would term, a, quote, epidemic of opioid use within the United States. Switching gears to San Diego, California, we know here that as a class, opioids are the #1 cause of drug-related deaths in San Diego. And similar to the national data, opioids account for many, many overdose deaths. In 2017, we had over 547 deaths in San Diego County, with fentanyl deaths and synthetic opioids on the rise. In 2016, 2017, and 2018, we saw a very large increase in deaths related to fentanyl as well. In 2018, we were at our highest at 85 individuals who had overdosed in that year. For Father Joe's Villages and the folks that are served within our housing interventions on site, we know that many of the individuals who come into our care are experiencing mental illness, addiction, and other disabling health problems. On average, 37% of the individuals within our housing programs report living with a mental illness. A quarter of the people who are in our housing programs report substance abuse disorders, and about 50% are reporting some kind of long-duration disability, which may include a physical health problem, a mental health disorder, or a substance use disorder. We also have a very large subset of our patient or client population who is in the age group of 50 plus. In 2017, we served about 30% of individuals who identified as Hispanic, 28% African American, and we had a large female population and a growing pay population that we've noted over time as well. So I want to tell you a little bit about some of the things that we are doing here at Father Joe's Villages to combat both the housing crisis that we experience as well as the substance use disorder needs. We know that at the end of the day, the only way to address both of these needs is to enhance stability for the individuals that we serve. And so I'll tell you a bit about some of the different programs and supports that we've put into place in order to do that. So as an agency, Father Joe's Village's mission is to prevent and end homelessness one life at a time. The organization began services in 1950 in downtown San Diego, and it began with handing out coffee and peanut butter sandwiches to individuals who are experiencing poverty. And in the 68-year history since we've been open, we've grown to be one of, if not the largest provider of services for individuals who are experiencing homelessness in San Diego, California, with a mission to prevent and end homelessness one life at a time. And our values are embodied within our creed, which is to treat all individuals that we interact with compassion, respect, empathy, empowerment, and also dignity. So within our on-site health center, we have an FQHC embedded within our agency, so a federally qualified health center on site. We're also a 330H grantee, which means that we are here to serve individuals who are homeless, at risk of homelessness, or who have experienced homelessness within the last 12 months. And we do that through pediatrics and primary care, dental services, psychiatry, behavioral health, mental health treatment, on-site MAT and substance use disorder treatment. We have a lab and pharmacy on site. We assist with insurance enrollment as well as specialty referrals. And our mission at the health center is to provide the highest quality health care to our homeless and at-risk neighbors to support our community in ending homelessness for these individuals one life at a time. We serve roughly 2,500 patients, unduplicated patients annually through our services, and we have an ever-increasing number of individuals who are presenting for substance use disorder services. Through our variety of programs, from chiropractic appointments all the way to individuals coming in for denture fittings, we serve folks through over 14,000 health encounters each year. One of the things that we've noted in our community, not only with homelessness on the rise in our community and also nationwide, but also with substance use disorders and opioid use disorders and the risk of OD continuing to increase. we realized that we have to change our services and supports in order to better respond to our community and patient needs. So when our patients' needs change, we have to be able to change our healthcare services just as quickly. One of the other things that really served as a catalyst for our particular programming was when many of our residential funders for our housing interventions on site elected to move to a harm reduction model, which meant then that there were many individuals who were coming into our services and attempting to engage in supports that had not achieved stability. And so we were working on looking at ways that we could partner with these individuals who are still using substances, maybe not interested in ceasing substance use, but certainly interested in housing, and how could we find a way to enhance stability while addressing substance use, mental health, disability, and other chronic conditions as well. So some of the resources that we were able to draw upon were many of these things that we already had pre-existing on site. We were lucky enough to have a motivated team that was composed of on-site alcohol and other drug counselors. We had providers who were already ex-waivered and had DEA licenses. We had a pharmacy partnership. We had pre-existing relationships with local residential and detox facilities and various providers in the area. We have a needle exchange location that's very, very close, within 2 blocks of our location. We had support from our organization as well as our board, and we began to seek out funding and other partnerships through a hub and spoke partnership that's sponsored by SAMHSA, and then also HRSA funding, looking at programmatic expansion very generally for our behavioral health department, and then more specifically for our medication-assisted treatment. And so with all of these other things in place, as well as the support of the overall village, which has a multitude of services and supports in our many departments on site, we kind of envisioned building this medication-assisted treatment program that would really meet the needs of individuals experiencing homelessness in San Diego, California. And what we found is we went to other experts. We didn't want to reinvent the wheel. We really leaned on our hub and spoke partnership for technical assistance. They were able to assist with providing funding for individuals who were in between insurance or uninsured. We were able to find a number of different ways to kind of supplement what we already had pre-existing and build upon these already great foundational building blocks so that we could build a program that we believe is really, really special and is meeting the needs of our patient population. To speak briefly about some of the other things that we can lean on site at Father Joe's Villages within our overall agency, we do have education and employment services on site, chaplaincy services, and health and wellness activities, and therapeutic childcare. So when individuals come into our residential services or when folks are engaging in services through our on-site federally qualified health center, we're able to align them with these other services and supports that, again, lean towards enhanced stability as well as quality of life. We're also lucky enough, as I've mentioned, to have a number of on-site housing interventions, including in emergency and bridge shelter, transitional housing and rapid rehousing, PSH, and other affordable housing options. We have a lunch line that operates daily, providing lunches to individuals who are still experiencing homelessness. We have a day center that serves folks from 6 a.m. to 6 p.m., 364 days a year. We have outreach and assessment professionals, as well as a team of security and canine supports that assure that all of our programs are safe. So again, going back to just the breadth of resources that we already had in place that we felt could allow us to make medication-assisted treatment services more useful to our population, these are some of the things that we were able to draw upon. So what we began by doing was establishing our hub and spoke partnership. From that, we were able to create policies, procedures, workflows, and forms. And so instead of reinventing the wheel on our own, we really leaned on these other experts and partners. We attended webinars, any conference, any training that would tell us a bit about implementing MAC treatment. And then we had to think about the way that implementation might roll out with our particular patient population and the way that the work would need to be modified in order to best meet their needs. So after we had an idea of, the workflows, after we had our consent documents and so forth, we began to do in-reach to the current patients that we serve and some light outreach with brochures and flyers to our community. and we began letting people know that we were planning to do medication-assisted treatment. When we began the treatment about a year and a half ago, we had just a handful of individuals who engaged, and we were doing that mainly on a one-to-one basis with a provider, with a medical provider assisted by an MA, a medical assistant. But I'll tell you a bit about how over time we've kind of morphed that model into something that seems to be suiting our programmatic needs and the patient needs much better. We began training immediately upon beginning medication-assisted treatment on site. We realized that as we bring in more individuals who are experiencing opioid use disorders, there is a higher risk of overdose on site in any one of our programs. And so we wanted to assure that individuals had the tools and training that they needed in order to maintain, to prevent loss of life. So we began training as many individuals as we could within our security team, our residential team, all of the teams that focus on care here on site 24/7, making sure that they were trained on administering Narcan and that they had it accessible to them at all times. We also saw additional grant funding and donor support through either private foundations, and as I've mentioned, HRSA has been a great supporter to us as well. We've scheduled monthly medication-assisted treatment team meetings, which are composed of our medical director, several ex-waivered providers, and our alcohol and other drug counselor team, our behavioral health director, and others who are involved in touching this process. So at least on a monthly basis, this group is coming together and continuing to promote changes to workflows, to policies, to make sure that this is evolving and really meeting our patients' needs in real time. We also have begun attending community events. In San Diego, we have an annual event called Project Homeless Connect, and we do attend events at our San Diego Day Center that we are affiliated through Father Joe's Villages, where we're providing education events on Narcan, where we're talking with people about medication-assisted treatment and various other forms of intervention for substance use disorders. So after implementation and really beginning to build and grow this program, as you can imagine, we have had a number of successes, and we also have had a number of challenges. And so I want to tell you a little bit about some of those different challenges that we've come across, some of the ways that we've modified our treatment so that if you are either considering a medication-assisted treatment program within your health center or within your agency, meant to address opioid use, you might consider some of these possible solutions as well in your workplace. So first, I want to talk with you about limited access. One of the things that we know about substance use disorder treatment in general is that it's essential that we meet patients where they're at. When somebody states that they are ready or willing to change and that they want assistance, it's really important that we hop to it. So it means that it's very difficult when somebody presents at 4 p.m. on a Friday and states, I'm ready. It's difficult to say, well, could you come back next week? Or could we get you an appointment a few weeks out? So what we've done is we've created open access provider schedules on many days of the week in order to assure that when individuals walk in and they state that they need assistance, that we have providers who are ready to take those on. We also make use of all of our canceled and rescheduled appointments and make those available to walk-ins. So we do our very best to keep our providers busy. It looks like from our most recent metrics, we're doing that about 80% of the time that they are in clinic. And so if somebody misses or reschedules an appointment, we put in a walk-in, and many of the times recently that's been individuals who are interested in medication-assisted treatment and addressing their substance use disorders. We do same-day induction on site whenever it is possible to that same end. And then we also refer to our hub through our hub and spoke partnership as needed. And that would be individuals who appear to need daily dosing, since as an outpatient facility, we're really operating more on a weekly basis, if possible. And then for those individuals who cite that methadone has been useful as a treatment for them in the past, we don't do that on site, and so those individuals are referred to our hub provider. We've noticed that with our patient population serving individuals who are experiencing homelessness, there are a number of no-shows. And so one of the things that's helped us in that particular space to continue to keep folks engaged is to really communicate well with patient supports. And what I mean by that is that we've worked out ways to internally share encrypted appointment lists with key contacts, including case managers, individuals on the residential team, and other supports for our clients so that they can then remind them, oh, I see that you're going to be going in for an appointment on Tuesday. How can I assist you in getting there? Or sometimes planning their case management or other appointments before or after to assure that that patient is brought into the clinic and continually engaged. We also allow our patients who miss appointments to catch up. And what I mean by that is if somebody misses a scheduled appointment, instead of saying that they have to go back to square one, we don't want to take a punitive approach. We might give them just a few days of medication and then encourage them to come back the following week as long as urine testing comes back in a manner that's acceptable. So we do some very light interventions in the beginning, and then we start to look at other options. It seems that it's difficult to get in on the days and times that you need. We start to maybe then coach on using other alternative methods like Vivitrol, which means that our patient would need to come in less often if they're using an IM medication towards their medication-assisted treatment needs. We've also considered recently expanding to street health medication-assisted treatment. We do have a street health team, and we're going to be piloting with them medication-assisted treatment to individuals who are street homeless and not engaging with any homeless service agencies, not engaging we would say, within our four walls. So folks who aren't engaging in services here within the clinic. So those are some of the different ways that we're working on those particular elements. And lucky for us, our program has grown exponentially. We began with a few flyers and some handouts, but really patient word-of-mouth marketing and our capacity to see people day of or within a few days who present for needed treatment has really grown this program really beyond what our initial capacity was and what we thought it would be. So in just Q1 alone, we had served over 90 unique individuals in this program, which was huge for us. And so it continues to grow from there. What we've elected to do is X-waiver more providers. We know that many neighboring clinics have maybe 1 or 2 X-waivered providers. We have 10. And so we continue to draw upon the resources of free Data 2000 trainings and so forth and get more and more of the providers who interact with patients X-waivered and signed up for their DEA licenses if they weren't already. We've also shifted to a MAT group model. So instead of having one patient to one provider, we've expanded to have several MAT groups per week that run for about an hour to an hour and a half. Those are facilitated by AOD counselors who are really emphasizing this community and support group model for our clients. And then the provider pulls each individual for about 5 minutes to 10 minutes each to discuss dosing, how things have been going, and really addresses their needs on the medical end for medication-assisted treatment and perhaps otherwise related to diabetes, hypertension, and other needs. And then they're released back to the group. So by having our patients come in a little bit early, take a urine screening, attend a group, and then be pulled to meet with their provider, we're offsetting a lot of that no-show rate. We're creating a support group for each of our patients, and that's really helped us to address the needs of many, many more people at one time versus having a limited capacity. So this is the way that we've really kind of stretched our capacity. We also provide individual sessions as needed, as I've mentioned, in terms of same-day induction and so forth. But we're really limiting those individual sessions to those folks who do not respond well in a group modality in an attempt to try and connect them with others. The main thing that I want to point out within all of these is that there are so many other wonderful treatment providers who are beginning to do these services or who are doing these services and have been for some time. Please make sure that you consult with experts, consult with other folks, attend webinars, trainings, and conferences, and pick the brains of other folks. We've just been so lucky to not have to reinvent the wheel. We were able to call upon a number of different resources that we had here on site and use some of the pre-existing strengths to our advantage. And with having the capacity to do that by drawing upon these other experts and the resources that we have on site, we've been able to build a program that we believe really addresses the needs of our community members and one that allows us to continuously adjust as our community and patient needs change. With that, thank you so much for your time. I've given you here a few other options in relation to how you can look into our various services and supports if you are interested. And my contact information is available here as well. And so I am greatly appreciative of your time and looking forward to some questions if there are any. I'll look at them in the chat. And I believe, should I be passing it off to Gina or to Ben?
Let's see. Megan, one question in the chat. What discussions have you had in your shop about reducing barriers to treatment, such as attendance in groups, urine screens, especially for those served by street MAT?
So that's one of the spaces where we are very limited. So we have a number of different facilities in the area where individuals congregate. And so some of the complexity are some of those places equipped with restroom access and so forth, so that we can attempt to obtain those screens and to do so in a very confidential manner. And so while it's easier to have some of those patient and provider interactions, it is more difficult for us to do the urine screenings in those places. So we are being very mindful of the locations that we're doing that. Because we have an on-site pharmacy, we're also able to draw upon that particular resource in order to have medications filled very quickly without having to go to outside pharmacies and so forth. And our hope is that ultimately those individuals will begin to come on-site to pick up medications on their own. And by enhancing their autonomy in that way, that hopefully we can begin to bring them into services and supports within the clinic itself. So the idea of implementing medication-assisted treatment on the streets is really to begin to kind of lay a trail of breadcrumbs, in essence, to get folks into other services and supports, whether it be within our health center or in the various other interventions on site. So we have begun these services, but only in the very recent weeks, and so I'll defer to other experts. I believe Ben can probably speak a bit more to that as well.
That'll be great. That'll be great. But yeah, good question. I really like that. Is sort of how, where do you have the dialogue about what are the barriers and how do you begin to look at those? And there's a host of barriers. It sounds like you've done amazing work there in San Diego about trying to overcome some of those barriers, but then, and that works for some people, but then other barriers remain, and you really got to think about it that way, and the way you have. So that's so impressive. So Gina, are we able to hear you? We've had some technology issues getting Gina on here. Gina, can we hear you? I know I'm not hearing her. Gina, you're not listed as muted. All right. I'm going to ask Ben then to be his incredibly wonderful, flexible self. And Jen, can we advance the slides? There we go, down to Ben. So Ben, you're on, and we're going to try to fix Gina's audio. Thanks, everybody.
All right, great. Well, thank you all for your patience and understanding. It's good to be here, and I'm happy to present today. So my name is Ben Cocchiaro. I'm a primary care physician. I work for Prevention Point Philadelphia doing MAT service with the street medicine team. I also work 2 days a week in a federally qualified health center where I do primary care and also some MAT as well. In the evening, I teach pathophysiology to nurse practitioner students. So I try to help folks develop mechanistic thinking about what's going on, and I think this presentation, I hope to discuss the scope of the opiate crisis in Philadelphia, to understand the state of evidence-based treatment, and try to identify mechanistically some of the problems with current implementation of medication for opiate use disorder programs. We'll then go on to describe an intervention that seeks to address some of these barriers, providing a service that meets patients where they are and takes them where they want to go. So we have an opiate crisis, over 1,000 overdose deaths in the last 3 years. This dwarfs deaths due to homicide, motor vehicle accidents. It is, in fact, third only to heart disease and cancer in terms of mortality in our city. And we can attribute this increase to several different factors. First, and probably largest of these, is the appearance of fentanyl on the scene over the last 5 years. Philadelphia used to be known as the city with the purest heroin. Now we find, based on street-based drug checking programs, that 9 out of 10 bags of heroin are either adulterated with or contain only fentanyl. Fentanyl, of course, a synthetic opioid 50 times more potent than heroin. I'm getting some things that I can't be heard. I'll try to speak more loudly. Fentanyl, we understand, is a synthetic opioid, 50 times more potent than heroin. Further, the duration of the effect for fentanyl is considerably shorter than heroin, requiring twice the number of daily injection events per day, up to 8 times. So we have a product that is less stable, less known purity, and needs to be injected twice as often as the brown powder heroin of old. This sets us up for a increased risk of overdose death. This is in fact what we see. Add to this some problems unique to the community that we serve at Prevention Point, which is increasing forces of gentrification in our neighborhood of Kensington, leading to small encampments that then go on to displace large numbers of folks from more stable encampments that have become in some ways a de facto supervised consumption site. These folks then are displaced into ever more precarious and isolated living situations where we find that overdoses occur. So these deaths are particularly jarring considering we have effective treatment for opiate use disorder, which we'll go on to now. I'm sorry, I'm getting some background sound here. Anyway, we've been using medications for opiate use disorder. This is the gold standard treatment for treating opiate use disorder as defined in the Diagnostic and Statistical Manual, Revision 5. This is the latest in a series of different terms that we've used to try to describe the situation. We see that initially we were using OST, or opiate substitution treatment. We ditched that because the term substitution validated some very spurious arguments about these medications being tantamount to swapping one addiction for another. Similarly, we ditched MAT, or medication-assisted treatment, because for many patients, the medications aren't assisting some other modality of treatment. They are the modality of treatment. I have many patients who come in one time a month. I make sure morphine or naltrexone is working, and then we get on to talking about the patient's other medical concerns. So now we've moved on to MOUD, medications for opiate use disorder, which seems to avoid some of the pratfalls of the previous two terms, and also directly invokes diagnoses they're used to treat. So we have three primary modalities. We have methadone, buprenorphine naloxone, and extended-release naltrexone. All have been found to decrease overdose deaths and decrease overall opiate use, though at present the data is a bit stronger to support the use of methadone and buprenorphine compared to naltrexone, because likely due to a particularly vulnerable induction period leading to higher rates of relapse. So we see some really profound outcomes in folks being treated with medications for opiate use disorder. We see that it saves lives, decreasing opiate overdose deaths, decreasing HIV and Hep C infections, decreasing skin infections, decreasing overall opiate use. We find that it saves money, not only on a societal or government level by decreasing criminal behavior and decreasing healthcare costs, but also by increasing patient income. I've had a couple of different situations in which patients have come to me, opened up their wallets apropos of nothing, showed me a stack of 20s in the wallets, and said, without the medication, this would not be possible. I would have spent this money this morning obtaining fentanyl. So these medications create space for healing and other important work in patients' lives, and they don't require total abstinence to work. This is, again, something that's been borne out by the evidence, which is that even when patients in medication for opiate use disorder programs are not fully abstinent, they still tend to die less, and they still tend to use less opiates, decreasing overall risk of opiate overdose. So we know that this works in primary care-based settings using a screening, brief intervention, and referral to treatment model. We know that there is specific evidence for its usefulness in federally qualified health centers. And yet we find also that there's a disparity in terms of the treatments slots that we've made available and folks who are able to use the treatments. So we're really only touching the tip of the iceberg here. This graph is from a cascade of care model paper by Williams and colleagues. This is the same Williams that came out with the HIV cascade of care that really helped us understand where we are losing people in the continuum of care for human immunodeficiency virus. There is now a similar model for understanding how we treat opiate use disorder. So Williams describes a country in which we have between 12 and 90 million people exposed to and therefore at risk of using opioids. We have perhaps 2 million based on national survey data that would suggest 2 million people meet the diagnostic criteria for opiate use disorder. And then we see that we're maybe only diagnosing half. Maybe only a third of them are being engaged in care, and a fraction of them are being initiated onto, again, what is the gold standard of treatment for opiate use disorder. Fewer than that are retained at 6 months, and a pitiful number of folks are then able to enter into remission, largely due to problems with diagnosis, engagement in care, and retention. So what's going on here? We see a situation in which we are building capacity and yet access is lagging. The total number of people in Philadelphia accessing medication for opiate use disorder seems to have plateaued somewhat in the last few years. We also notice that we have an excess of available treatment slots. So almost a quarter of our slots at the end of 2018 were empty and available. So we have to ask ourselves some very probing questions about why this is. So there are barriers. Our health system asks enormous things from folks who are in very difficult circumstances, and oftentimes we punish them brutally when they stumble. A 2013 review of MOUD program discharges found that 42% of folks were discontinued from the program before 6 months, and nearly half of those folks were discontinued involuntarily. When you probe into why that was, we find that logistical issues played a role, and part of that involved daily attendance requirements. We found that about a sixth of the folks who were discharged could not meet those requirements and were discharged for that reason. Mandatory requirements on abstinence or treatment adherence, also a source of involuntary discharge. And then finally, 25% of these folks cited conflict with program staff as the main reason why they left the program. So why is this? We see stigma as a massive cause of conflict. This is rooted in our outmoded theories of substance use and its treatment, specifically absolutist 12-step ideologies. We see this rooted in racism and implicit bias that we have. And finally, rooted in countertransferences, in which we project our own negative relational experiences with substance use onto our patients. And we're doing this in a profoundly traumatized population of individuals. You see this map with overlaid dots. The darkest green segments of the map are zip codes in Philadelphia, where more than 45% of respondents were found to be exposed to 4 or more adverse childhood experiences. And as we know, adverse childhood experiences are exposure to poverty, abuse, neglect, racism, violence. Trauma contributes to the risk of a person developing opiate use disorder. For every adverse childhood experience, your overdose risk is increased by 10%. And the population attributable fraction for injection drug use is almost 2/3 could be explained by exposure to 4 or more adverse childhood experiences. So you have this double-edged sword in which trauma is contributing to the risk of developing opiate use disorder, but also impairing individuals' ability to process the stresses associated with navigating what are oftentimes Byzantine care systems. So based on this realization, we try to think about designing programs that realize the widespread impact of trauma and understand potential paths to recovery for folks, recognize trauma in the folks that we're working with, and in our own staff. Trauma-informed care is not something that you practice on the population you serve. It's something that you practice as an institution with not only the clientele and patients, but also with your own workers. And we respond to trauma by integrating knowledge about these trauma into our policies, procedures, and practices, thereby reducing and resisting re-traumatization of these populations. So I'm going to describe now an intervention that we've been running for the last few months at Prevention Point. So we use an ecological approach, starting with a cluster of services available in one location, which is the quote-unquote BUP bus, a mobile MOUD program that Prevention Point started. The bus is parked, initially we were parked outside of a homeless encampment along Lehigh Avenue. You can see the background image there is facing south on Lehigh Avenue, roughly 250 feet away from the encampment and 2 blocks from where I currently live. The bus offers a core number of services with a low demand model that seeks to engage folks in care. And then we link folks to the 6 blocks down the road from where the bus parks. What's notable is that Prevention Point started as an underground mobile syringe exchange program and is now a multi-service public health and harm reduction organization that offers all of the services that you can see here in green. So not only what's available on the bus, but also we have a shelter program. We offer meals. We offer an address and mail for folks. HIV, Hep C testing and treatment referrals, as well as a syringe service program. The core team on my bus is a medical provider, a wound care provider, a case manager, and a certified recovery specialist. So the case manager will provide initially a biopsychosocial assessment, identifying immediate needs, goals, and resources for the patient. The recovery specialist will meet with the patient to discuss recovery goals, motivations, and can even escort them to community and recovery supports. We have additionally linkages to homeless outreach teams that can then refer patients back into us. We practice a rapid intake on demand. We have no appointments. We roll up at around 11 and we leave between 3 and 4 p.m. We try to see as many people as we can in the meantime. We do point of care urine drug screens, same-day assessments and medication starts, and mobile follow-up. We used to bring folks back 1 to 2 days after initiation. We found, however, this resulted in very poor follow-up, and that by increasing the duration of our prescriptions to 7 days, our retention rates improved greatly. Later on, after folks are stabilized on the medication, we tend to transition them into primary care settings or intensive outpatient MOUD combination programs, or into our headquarters where we offer all of these services under one roof in more of a stationary model. So where does this get us after about 6 months or 5 months? We were able to enroll 118 new patients, 80% of whom were homeless or unstably housed. 61% were insured at the time of enrollment. And we noted that polysubstance use was very common. K2 and cocaine seemed to top the list, with K2 being cited by many of our clients and patients as a large barrier to retention and care. However, despite these challenges, 76% of folks returned for a second appointment, and 34% of patients were retained in the program at 120 days. This is a number that is consistent with other mobile MAT programs. There was recently a paper out by Krawchuk this year describing an intervention with recently incarcerated individuals in Baltimore County, finding very similar numbers. We noted several challenges, problems associated with adherence, homelessness, polysubstance use, exposure to violence. Again, the cycle of trauma doesn't end when they enter the bus. It's something that we have to provide supports for continuously as we meet and serve the patients that we're working with. there have been several logistical challenges. First of all, we have a demand that greatly outstrips our supply. And this, smaller logistical challenges, such as ways to collect doses in a dignified manner. This was a unique challenge that now we have partially solved through a partnership with a nearby behavioral health agency that has allowed our clients to use their facilities. So finally, we have these cultural and stigma issues that I mentioned a couple of slides back, and we find them just as challenging on our mobile unit as they are in other settings. So I want to take a step back by about a century and a quarter and just try to figure out if we've made any progress on our opiate crisis in the last 127 years. The College of Physicians in Philadelphia met in 1892 to discuss the opium epidemic. And here you see Jamie, a physician from New York, who came down to read his paper, describing that no physician is warranted save under circumstances peculiar and beyond control in subjecting his patient to the torturing ordeal of withdrawal. Opium addiction is curable in the sense that other diseases are, that permanence of cure depends largely on favorable temperament and surroundings. So you could take this to be a pessimistic look, that we haven't made very much progress at all, that we've been saying the same things over and over again and that not much has changed. Or you can say that, no, we've expanded access to care, that despite the Harrison Act of 1914, finally we're starting to use medications again in the treatment of opiate use disorder, and hopefully that we see our patients getting a little bit better too. So in conclusion, we know that opiate use is socio-relational and chronic. It's related to trauma, and if we don't address trauma, we're not going to address opiate use disorder. We know that this is an immediate problem, that people are dying, over 1,000 a year in Philadelphia. We know that our progress in many ways is stalled, and that there are barriers preventing most folks from accessing treatment if we think back to that cascade of care model. So it's up to us to bridge this gap. We have to address stigma, and it's going to go way deeper than just trying to use person-first language or switching from MAT to MOUD. Staff need to be trained in developing a neurobiological and socio-relational understanding of substance use, understanding the role of trauma in substance use, and then figuring out ways to check their own biases and countertransferences. Even deeper, we need to start thinking critically about the silent ways in which our programs discourage participation and create animosity between staff and patients. We can do this by designing for trauma-informed practice. We can do this by co-locating our services, and when we can't, providing strong referral networks with warm handoffs to known providers who we know work well with the patients and the populations that we serve, especially for housing and behavioral health. We need to meet patients where they are and help take them where they want to go, allowing for multiple concepts of recovery. And then finally, we need to practice systems-level advocacy, not just on small things like figuring out our prior auth issues or figuring out why it is on earth that every provider needs to be specially waivered to provide buprenorphine treatment, but can write as many Percocet prescriptions as they darn well please. We need to think from a harm reduction standpoint and a decriminalization standpoint, and we need to meet folks again where they are, throw the life preserver in a way where they can catch it, and take the patient somewhere where the patient wants to go. That's all I have to say. I'm happy to answer any questions or pass it on to our next speaker. Thank you.
All right, getting myself
Hello.
off mute. Thank you so much there, Ben. Oh, Jean, is that you?
Yes, you can finally hear me, and I can actually hear you and see you. Amazing. San Francisco, the city of technology, and we can't figure things out over here. We're switching to Epic, so all our computers are a mess right now, new electronic medical. All right, so I'm going to be presenting on our low barrier buprenorphine program for people experiencing homelessness here in San Francisco. It is a street medicine approach, and most of these slides are pertaining to our pilot program, which we started in 2016. All right, go next. Oops. I don't know where we went there, but there we go. This is just a quote from Maya Angelou. It's reflecting a lot of what Ben was talking about. I call it restorative medical care. I expect that everybody that walks through our door or that walks in our path, because obviously a lot of times we're not in a building, has been traumatized by the medical system in some way in their past, if not really, really hurt by the medical system. And I feel very strongly that it is our job to fix that and to be the ones that are really able to give the patient the care that they need and the compassion and not be judgmental and give them a good experience of medicine. So when they're ready to move on to primary care, we have resources and they can feel comfortable doing that. Okay, so this, we're going to basically talk about how this pilot came to be and what the goals were, identifying and addressing barriers, a little bit of the procedure and results, and some successes and challenges. Okay, so here's a little bit of background. In 2016, the mayor at the time was noticing on their way to work that there was a large amount of people injecting publicly in Civic Center Plaza, along with the co-occurring deaths that were going on every day from overdosing. This caught, of course, their eye because of the general public. San Francisco is a very touristy town, as you know, and people were complaining. Needle waste, it's visually disturbing. You know, San Francisco is a beautiful city. Why is this going on? And the patients the people that were shooting up were typically unhoused and have severe opioid use disorder and had many, many barriers to treatment, to accessing treatment. Okay, let's see. So our target population, of course, is unhoused people who are injecting drugs in public, not able to access care otherwise available in San Francisco, or have tried and just can't do it, or have been kicked out of programs, like I was seeing a lot in the chat. What we needed to add to our team, our very, very small team at the time, was a full-time outreach specialist to help us go out and find people that were interested, and also to help us kind of figure out where to be, because we just started going out into the streets and doing this. And our goal was, of course, to increase access to buprenorphine treatment for people that can't access it. Okay, I'm going to do a quick case that we have with Mr. B. He's a 45-year-old man. He presented to our needle exchange clinic for buprenorphine, and he started saying basically he's afraid that the next shot he does will kill him. In red, you can see everything that's circled that were reasons why he was having trouble getting buprenorphine in a traditional setting. A lot of times he had multiple skin infections that were very stinky, and nurses and doctors like to go straight to that stuff. High risk sexual activity, antisocial personality. That's a big one that we get a lot. He had his last provider with a TerraSoft. He's been homeless most of his life. He did not have benefits. Here in San Francisco, we have a little bit of different picture than the rest of the nation. We're seeing heroin and methamphetamine more than anything else. So this gentleman was right there with that, heroin and methamphetamine, and the longest he'd ever stayed in treatment was 48 hours. And he'd been denied pretty much everywhere else since then. Okay, so here's the barriers for the providers and the patient. Patient can't trust a provider. Talked about that. Restorative health care. Can't get to an appointment. Can't get the medicine for whatever reason. Doesn't have an ID. Can't pay the copay. Whatever the reason may be. Just can't figure out what Walgreens to go to. There's many, many reasons. We all know this. The providers won't provide because they want patients. There's a lot of providers that want patients to just stop using completely. They want to be in and out and get things done. And we all know that these are very complex patients. This is not a quick situation. We're in it for the long haul with our patients here. And of course, we're like, man, they won't adhere to any treatment plan, which is frustrating. Okay, so here's again Mr. B. And again, here's the things that would tick off most of in red from the provider's point of view. Oh, this is the kind of person that, normal provider, oh no, this guy's never going to make it. Maybe get 2 seconds into the intake and that's it. I'm sorry, my coworkers are very loud outside the door, so I'm trying to tune them out here. Okay, so what we decided to address to do this was to break down the barriers. What we had to do was first identify those barriers, which we did. You saw with Mr. B. Can't get to appointments on time. Can't get to his pharmacy. Isn't housed. Isn't anywhere where we know he's going to be. So this is where we've decided we are really doing our best work, is of course with harm reduction. People stabilize when they get housing. When we start seeing them, we start working on that. We have a pharmacy component. We do have a mental health pharmacy here that is our partner, and we are extremely fortunate to have that because it's more like illness. They can actually go in and consult with the pharmacist, and the pharmacist will look at them and say, oh my gosh, you're very sedated. Why don't we sit down for a little bit? It's not often you get a luxury like that. And also, we can get buprenorphine free through them. So that's been an amazing resource. The limitation with them is that they're only open certain hours Monday through Friday, of course. We also decided we have to take everything to the street. 4 walls clinic doesn't really work for our patients all that well. Not to say that they won't ever come in, but what we have found is that if we start them at places like streets and parks, syringe access sites, navigation centers, which you see up here. We actually are working with the inpatient hospital team to start patients or restart them on their buprenorphine there. And also when they're getting housed, if their opioid use disorder is something that might cause them to become unhoused again, we will start them when they're in housing too. When they're ready to go that way. Okay, so this is where we are finding the most success. Syringe access, and we're actually now at 1, 2, 3, 4, 5, 6 syringe access sites, very different ones, different neighborhoods, some for youth, some for everybody. We also do couples inductions or couple starts at our 6th Street Harm Reduction Center one. It's just a little bit non-traditional. We have our open access clinic, which I was really excited to hear Megan say open access because this is like my 15th year of doing an open access clinic. Our providers are here 5 days a week for a half day. Any of our patients can come in during that time and be seen by one of our doctors. And because our team is small and we know most of our patients and we talk every single week in case conferences, we are able to do the wraparound care. And then also it's something which is called navigation centers, which some of you may have heard of and some of you may not have heard of, but they're kind of like shelters where you could have all your stuff, your pets, your partner can stay with you, that kind of thing. And those, because they are just low barrier and we're able to have a little bit of clinical space in there, we're able to use it. And I know people are going to ask about UTOXs and stuff like that. These places all do afford that. Streets and parks, it's a little bit harder. And sometimes in our outside exchanges, we do some point of care testing when we can use, like, at one of our sites is near Safeway that lets us use the bathroom, that kind of thing. So, okay. So, and then accessing medication in general is a barrier for our patients. They're like, they don't have Medi-Cal or Medicaid or any medical insurance 99% of the time. They also don't have an ID. So if those two things are not in order, We can still start them the same day because we have our community behavioral health pharmacy, which is amazing that we're able to access that. That's not often that you're able to do that, but I can just send, say, Mr. B down to CBHS, or Community Behavioral Health Pharmacy, with a letter saying Mr. B is wearing a Pokemon shirt. Please dispense his medication, and they're fine with that. Okay, so this is basically what the pilot procedure was. The assessment, of course, outreach and engagement, trust building, and a comprehensive assessment by a medical provider. That could happen in or out of the clinic, in a park. Wherever they are, that's where we're at. We do buprenorphine starts usually short the first time, 2 to 4 days. Unlike Ben, we actually found that the 7 days, we weren't getting people returning after 7 days, but when we did 2 to 4, they actually liked it better because they wanted to see us a little bit more, which was interesting. And these are all non-facility-based buprenorphine starts. Typical follow-up is weekly to biweekly, definitely no less than every month. UTOXs, screens on a schedule determined by the clinical indications, patient stability, and patient preference, which is a little bit different because we all know that, a lot of patients just shove a urine cup in your hand. We actually, because we're doing motivational interviewing and trauma-informed care, most of my patients will come in and tell me, Gina, I'm not going to have you from my urine today, or I am going to have you from my urine today. Not to say they won't have anything else in there, but if I see the buprenorphine in there, I'm pretty happy. Okay, so this is a little bit more about Mr. B. He has started medications since this is a little bit of an old presentation. I want to say about 7 to 9 times. We were able to help him because, as you remember, he had a TerraSoft, he has an antisocial personality, because we have on-site counseling through the Harm Reduction Therapy Center. Tongue-tied, need lunch. Harm Reduction Therapy Center, which is also an amazing resource that we have here in San Francisco. But he would lose his medicines all the time. The small prescriptions, 2 to 3 times a week, that was money for him. Urine tox negative for buprenorphine. So in that case, we do something called intensifying treatment. He had observed dosing at a pharmacy 5 days a week, and with then his additional doses to go and take homes on the weekend. His overall health and function were really, really starting to decline. So we've actually gotten him engaged in much higher level of medical care because he is a very sick guy. And because he is able to trust us, go with our outreach worker, and not be sick, he's been able to actually make some of these referrals to higher levels of care, which is great. Okay, so here's our evaluation. Characterizing the population participating in low barrier buprenorphine, assess maintaining in treatment, and assess reduction in opiate use. Okay, so you can see who our average people are: white men, which is not surprising here in San Francisco, and their age range is they're about 39.2, because we're at a couple sites that are specifically for youth. It's a little bit skewed down, I'd say, than some of the other programs in the city that aren't as youth involved as we are. But at our other sites, they tend to kind of be older Caucasian males. Our patient population is high risk, high vulnerability. They, as I said before, have co-occurring substance use. We mostly see opiates with methamphetamine here, a little bit with cocaine, and with alcohol as well. Most of our patients, as you can see, have a psychiatric diagnosis, and many of them are very medically complex, 2 or more serious, and a good portion of them have previously sought treatment at another location. And here's the results of the pilot from 2016. So in the red line is retention in actual just medical care. In the blue line is retention on bupe. So what's interesting that you see here is even if our patients reduced their retention on buprenorphine, which it dropped at first and then kind of steadied out a little bit, the patients were still more likely to be still engaged in regular medical care, which was also one of our unstated, kind of goals at the beginning, which is really great. Some of these people who are not on buprenorphine anymore were transitioned back to methadone because that was their preference, or just didn't like the buprenorphine, but they're still engaged with us, which is great. And then this is just some stuff about our UTOXs. Again, it's very patient-driven, our UTOXs. You can see we don't do tons. Average test is 2.7 because we really actually do trust what our patients tell us, very much so. Very rarely after we become engaged with the patient have I had them not actually kind of straight up tell me what was going to be in their urine. And as you can see, 79% of our people have buprenorphine in their urine. A lot of them also have opiates, and then you can also see the red line is co-occurring with methamphetamine, and then we have coke and benzos a little bit farther down on the line, which again I know is different than most of the nation. Okay, and then so you can see we've had at least, from all of those patients, 34% had at least one opioid negative UTOX, and 14% had all of them negative. So that's interesting as well. And that was part of our original goal, reduction in opioid use. So, and that's mostly to address things like skin infections and other. We want people to kind of do some harm reduction around the rest of their health care. And this is a summary of what we did during that time. This was from November 1st to October 1st, so a year. We had 95 patients that were evaluated and received at least one prescription. They were all high risk and high vulnerability. 80% had co-occurring substance use, major psychiatric and complex medical needs. Of the patients who had any follow-up in urine tox, a third of them at least had one opiate-negative urine, 14 had abstinence from opiates on all their screens, and almost 80% had buprenorphine in their system. And that's really important to note because, as we know, buprenorphine fills those amazing receptors in our brain, and they are a little bit protective against overdose. So if we have patients that are totally unstable and they're on bupe and then they decide to shoot up a whole bunch of fentanyl, it's nice to see that they're taking the bupe, and hopefully some of those receptors are blocked off by the bupe, and that can help reduce the risk of overdose. I'm not saying that it fixes an overdose or anything like that. It just helps reduce the risk, which is huge in the day and time that we're living in here. And then, of course, addressing the barriers to accessing buprenorphine resulted in decreased opioid use and improved overall health for this high risk and high vulnerability population. And here's where we are today with Mr. B. He is on a long-acting antipsychotic injection and responding well. He continues to engage with us. He was here 4 days this week, in fact. And 2 of those days he had like major mental health issues and was able to, with the help of our amazing outreach worker, de-escalate himself and manage his behavior in the clinic as to not get kicked out by the sheriff, which was just a huge improvement for this man. And he's on the list for supportive housing, and he's been accepted into intensive case management. Of course, his ongoing challenges are his continued chaotic substance use. He goes in and out of using buprenorphine, and then also using methamphetamine, which it's very challenging. He has a lot of soft tissue infections, so that is unfortunately not decreasing as much because he uses substances and injects them all. And he's still homeless, and because of his behavioral issues, he has been getting denied service at a lot of even the lowest barrier sites, which is very, very difficult. So, those are still some of his barriers, but even with all those barriers still there, he came in 3 days this week, which I consider a huge success. And here we are today. We started with a team of myself, Dr. Zevin, Shannon Ducharme, an amazing health worker, outreach worker, Leah Warner, our nurse practitioner, and a small army of per diem nurses, 3 others. And we are now, this is our entire team of street medicine and shelter health, and we are now have about 500 patients that have been started through our low barrier treatment. Retention continues to increase even with the original cohort. A lot of them came back a year after treatment, which was really, really amazing. So our program has grown, and we have been funded to grow even more. So we're hoping to expand to even more sites. And I think that is the end of my presentation.
That is, Gina, thank you so much. Thanks to all our presenters today for both their incredible work every day and also for bringing all of that information together and sharing it up so we can think about what it means for our practice. We've got a question that I think is for all of our presenters today. I'm going to encourage them to all get off mute so they can answer. How do you get the buprenorphine to the patients once you give them? Are you dispensing meds to the patients in the streets? Gina, you're probably still on. We'll start with you. You're dispensing to folks on the street, correct?
No, we're not dispensing the actual medication on the street. We're dispensing the prescription on the street, and then they go to our behavioral health pharmacy or sometimes a Walgreens or a Safeway to be fair, we have nighttime sites, and that's all we have the option for to pick up the medication.
Okay. Ben, what about you? How do you handle this issue?
Sure. So we have relationships with a few local pharmacies, one of which will take our patients even without insurance, and nerves can pull our account for folks who are still waiting to get insured. We are working on pilots at the medication program at our headquarters to dispense directly from Prevention Point headquarters. We're not quite at a place where we've been able to do it off of our mobile unit yet, but we're investigating some of the legal constraints that are seeming to be barriers right now.
Okay. And how
I just wanted to say really quickly that I typed in our website that we have live now that it will answer a lot of questions about our program. So everyone can have that website too. It's for you to learn and grow. It's a teaching website.
That sounds great. If you can maybe put the link in the chat box, that might help people as well.
I did. Yeah, it's there.
I don't think it went to all participants. I know I'm not seeing it. So yeah, you got to watch and make sure that it's not who it's directed towards. Have to participants or all panelists. It might have said, yeah. Okay.
I said all attendees. I guess it didn't get it.
Oh. Okay. Well, good. That's probably why I'm not seeing it. It'll leave us out as panelists, not attendees. But it's most important it gets to the panelists. I'm sorry, to the participants. Excuse me. Awesome. And Megan, anything on your end you want to share about what you're doing in San Diego? There we go.
We're going to, our plan is to direct folks to the closest pharmacy access points that they have. So it would really be dependent upon where they're located within our community. We provide street health services within a mile of our clinic, and so we know and are partnered with many of the pharmacies within that space. So we're happy to send the prescription to wherever it is that they might need it. There's also a few partner pharmacies where we're able to obtain those medications free of charge through our hub and spoke partnership for individuals who do not have insurance. And so there are other specific places that we might send them with vouchers to obtain those medications there as needed. And ultimately, our hope is then to redirect folks, like I had mentioned, to the on-site pharmacy so that we can try and get individuals engaged within our full host of programs here on site.
Great. I know financing is a real barrier for folks on this one as well. And any strategies you have around that one? I know the two states we have presenting, California and Pennsylvania, are both expansion states, and I'm sure this is a bigger barrier, much more challenge for the non-expansion states who are joining us today.
Yeah.
Anybody who's from a non-Medicaid expansion state that's joining us today. But suggestions? Any suggestions from our panelists on ways to finance actually getting that? I know that every time we send someone to, even if we break down all the barriers, every time there's just one more step, we lose people in that step. So
I know that Sacramento County is a little bit different than us, and I've talked with their program extensively, and they have to do a lot of like prior authorizations to get their buprenorphine up there. And so they have this kind of little spitfire health worker named Mindy, who once she does the engagement, she finds out someone's interested in buprenorphine, she starts all the prior auth stuff like right away and can usually get it authorized within a couple days. So while it's not same day, they're doing kind of, the best workaround that they can.
Yeah, in Philadelphia, we've experienced sort of similar situation where having a good caseworker who can process prior auths quickly can help address some of these access issues. I think notably in Philadelphia, all of the Medicaid servicers do cover buprenorphine in its tablet formation. We do have some folks who don't like the tablet formation for understandable reasons. It is considerably less bioavailable than the film preparation.
Yeah, the film strips.
So like 30 or 40% less medication actually gets into the system. So when you're prescribing 8 milligram tabs, you're getting closer to 6 milligrams in the system compared to a more complete bioavailability for your film preparation.
We actually also started Sublocade in this past 3 months, doing low barrier Sublocade, and that has been a lot of the same thing. I have to have a nurse assigned to that project because it takes a lot to get through the prior auths and whatnot. If you don't know what Sublocade is, it's a long-acting injectable buprenorphine formulation. It lasts a month.
All right. And that, I believe, is all the questions I see in the chat. Anyone else? Give me a minute here. All right. Well, then, you busy people, there's 10 minutes back in your day. Thank you, everybody, for joining us. Thank you to all of our panelists, as I said, most importantly, for the great work you do every day, but also being willing to share that work both across your communities and now across the country. So thank you, everybody. Any questions, please be in touch. You've got my email up there. And if folks are doing also innovative work that they want us to highlight, we'll be writing a brief over the next year on innovative programming in this area. And so please be in touch. Thanks, everyone, and have a great afternoon.
Thank you, Marcella, and thank you, everybody.